Welcome to our Facebook Live Q&A today. I'm Dr. Amy McKenzie, and this is Dr. Stephen Phinney. We are researchers here at Virta and collaborators on quite a few different research studies together. Today we're here to answer any questions that you might have about diabetes, heart health, ketogenic diet interventions, anything you can think of. So please list your comments and questions below the video, and we'll get to as many as we can.
And as we answer questions today, we want you to remember that we cannot give specific medical advice. So our answers to questions will be general rather than specific. And for specific medical questions, we would refer those to your physician.
So our first question today is, how does Virta's treatment affect heart health? This is a very relevant question because we just had a new publication come out today in cardiovascular diabetology that really focused on this. So we had published, maybe 2 months ago now, we had published the 1-year type 2 diabetes outcomes. And we showed that A1C improved, we showed that glycemic control was better, insulin resistance was better, weight improved. And in this paper, we really focused on all the different risk factors around cardiovascular disease.
And that's important because in the diabetes paper published 2 months ago in Diabetes Therapy, we noted that although a whole group of diabetes-associated risk factors got better, one of the more controversial changes is that the LDL cholesterol level in our patient group as a whole rose slightly but statistically significantly. And so we felt that it was important to take a much closer look at the full range of heart disease risk factors, and that is what's encompassed in the peer-reviewed paper that we had published just today and can be accessed through our website.
Yeah, so to give kind of a brief overview of what we showed in that paper. So Steve mentioned the rise in LDL and the LDL-C in the group on average, but there are a few markers that some researchers believe might be a better predictor of cardiovascular risk, or at least equal to LDL-C. So those are LDL particle number and ApoB. Those two markers statistically were unchanged at 1 year in our cohort of patients. And then we also looked at the particle size. So some believe that small, dense LDL particles might be more atherogenic than the larger particles. And our small, dense LDL particle number actually significantly decreased at 1 year. And the particle size of all of the LDL particles increased at 1 year. So in terms of looking at the whole picture of risk, we certainly saw that increase in LDL that a lot of people get concerned about. But when you put all of the markers together and consider the whole risk profile, we're definitely getting an improvement in a lot of different risk factors. And then we still are concerned about LDL, but we see a lot of improvements in other ways. Mm-hmm.
And understand that the test that we use to measure LDL particle size and number is a new test. It's not universally available. It's predominantly a research-based test. And there are a couple different ways that these can be analyzed, and the medical practice community has not arrived at a kind of a uniform recommendation for these values. So this is a research test that we did, and it may not be available to the average person through their primary care physician. For instance, I saw my physician a few weeks ago and I get my health care through Kaiser Permanente here in California, and I asked if they could run the LDL particle size and number for me, and said, no, we don't do that. Yeah. But it's important that other factors that we did look at, such as HDL cholesterol, which is so-called good cholesterol, and triglyceride values, then those are part of a standard lipid panel. When the ratio of HDL to triglycerides goes up, that is, you have more HDL relative proportionally to triglyceride, that is correlated with an improvement in LDL particle size and number. Mm-hmm. So again, we've looked at, I think we had 18 different cardiovascular risk factors in this current paper, and those are included in that. So the point is, this is a very complex area. It's an area of active research. But what we want to provide is a broader perspective of all the parameters, rather than focusing on what we have with the cholesterol diet, heart, hypothesis where the focus for a couple decades has been just on the LDL. The true picture is much more complex than that, and we want to get into some of those details.
Sure, and there's evidence even to say that the picture is more complex from the EMPA-REG trial, because they put people on SGLT2s. They saw LDL go up, but they saw cardiovascular mortality decrease.
Dramatically.
So,
yes.
38%, I think, maybe. So there's definitely something to say where there are other factors at play, and it's not all about one lipid marker in terms of cardiovascular risk. So we'll find out someday.
So before we get into specific questions, do we want to talk about the range of risk factors that we looked at? So responses such as hypertension, inflammation.
Yeah. So I think also when we're talking about different risk factors and looking at the whole risk profile, inflammation is also an independent risk factor for cardiovascular disease, and many consider it or hypothesize it to be potentially an underlying cause. So we looked at a few broad markers of inflammation in this study. We looked at high sensitivity C-reactive protein and white blood cell count, and both of those dramatically improved. The CRP response especially was pretty astonishing at 1 year. And then blood pressure as well. Blood pressure significantly increased, and the really cool thing...
Actually, decreased.
Thanks. Improved, decreased. So blood pressure decreased, so it improved. And because of this, we actually had to deprescribe medications for the patients because they didn't need the medication anymore. So that's a really unique finding too.
So a lot of patients move from the hypertension, borderline hypertension area to normal blood pressure with a reduced total medication use in the population, which is a very unusual finding, because usually the way with standard medication treatment for hypertension, you have to give more medications to get better control.
Sure.
We got better control because nutritional ketosis and the Virta treatment that embraces and supports that is such a powerful metabolic tool.
Yeah. So that's a little bit of a recap on our cardiovascular risk factor paper that just came out today in Cardiovascular Diabetology. You can go to our website, virtahealth.com/research, and you'll find the link to that paper there. And then we'll have certainly more information coming out from Virta tomorrow about that. So check back tomorrow and we'll have some more information for you. So our next question, is it okay to eat 1 to 2 meals per day with half of your protein needs in each, or is it better to space out your protein?
That's a good question, and it actually kind of leads to the concept of time-restricted eating.
Yeah.
And we actually did a blog post a couple months ago entitled "To Fast or Not to Fast." And in that, we point out that there is actually a fair amount of published research on time-restricted eating. As long as people don't do total fasting for more than 24 hours, certainly skipping 1 or even 2 meals per day, when the composition of those meals is appropriate, is safe, and for some people turns out to be an effective tool. And so yes, protein doesn't have to be eaten in 3 equal portions. It can be eaten in 2 portions. And there's some people who find that they eat 1 meal per day. So they're basically fasting from basically dinner, let's say one evening, till dinner the next evening. And that as long as that is interspersed with adequate nutrition, including adequate vegetables for potassium and other minerals and fiber on the non-restricted days, it can be a healthy way to follow a well-formulated ketogenic diet.
Sure. Protein is important, so it is important to make sure that you get it in and meet all of your needs. And then if you are in the situation where you're eating protein in this way, where you're kind of lumping it all into one meal and your ketones don't go down, don't be too surprised, because that might also be a factor too. So depends on what your goals are, but it is definitely really important to get in all of your protein. Next question. Is keto safe and or recommended if you have no thyroid? And is there a risk of low TSH if you do keto without a thyroid? Doctor?
Yeah, it's a good question. Again, we have to be careful not to give specific medical advice. But in general terms, taking thyroid medication can fully replace what the thyroid gland normally does. And it's important to point out that the thyroid gland doesn't make active thyroid hormone. It makes a precursor called, well, we just say it's the precursor that has 4 iodine molecules on it. Active thyroid has 3. The thyroid makes the one with 4. Your liver takes away one of those iodines to make the 3. So you can take the thyroid hormone by mouth, and then the liver does the final step and can regulate much of that process. And TSH is a useful test because that's a measure of what the brain perceives in terms of what the liver is doing. And so that can be used by your physician to help judge the dose of oral thyroid medicine that is prescribed. So again, this is something that has to be managed between you and your primary care physician. We can't give you specific advice for that.
Sure. Oh, great. So if you're just joining us, I just want to welcome you to the Virta Facebook Live Q&A. I'm Dr. Amy McKenzie. This is Dr. Stephen Phinney. We're here to answer your questions about diabetes, heart health, and ketogenic interventions. If you would like to be notified of future Facebook Lives or events, please follow Virta on Facebook. Great. Our next question is, can being in a state of ketosis enhance your athletic performance? I think this is something near and dear to our hearts.
Yeah, wow. Do we have an hour?
Yeah, I think we could spend a lot of time on this. So our collaborator, Jeff Volek, that is at Ohio State and also a co-founder of Virta, he actually has been looking at this a lot lately in his research. Back at UConn a few years ago, he brought in 10 high-carb athletes and 10 keto-adapted low-carb athletes, and they were
these were elite ultra runners.
Yeah, elite ultra runners that did ultra marathons, or some of them were triathletes. So it was elite ultra endurance athletes, and 10 of them were keto adapted, and 10 of them were on a high carb diet. You brought them in to run for 3 hours, and looked at all of their performance during that time and then during recovery. And probably not surprisingly, the low-carb keto-adapted athletes had higher peak rates of fat oxidation and a higher mean rate of fat oxidation throughout the run. But the really interesting thing is that when it comes to athletic performance, people seem to be concerned about muscle glycogen. And they're worried that if you're low-carbohydrate and keto-adapted, that you're maybe going to run out of muscle glycogen, feel like you hit the wall and not be able to perform. So they did muscle biopsies in this study, and what they found was that the keto-adapted low-carb athletes and the high-carb athletes had the same amount of muscle glycogen, right. And then it followed the same pattern even in recovery.
Yes.
So after the 3-hour run and then also 2 hours into recovery, muscle glycogen was all the same.
Mm-hmm. But the difference between them was that because the keto-adapted athletes were burning fat at twice the rate, providing 80 to 90% of the fuel during their endurance run at race pace. So as Amy said, they had them run on a treadmill for 3 hours in the lab.
In the lab, staring at a blank wall.
And the keto-adapted athletes mobilized muscle glycogen at the same rate, but it appears that they recycled it. They didn't burn it all the way to CO2 and water. So it was like basically recycling that same carbon, so they didn't need to eat a lot of carbohydrate in their diet in order to regenerate and maintain muscle glycogen stores. But from a broader perspective, how might a ketogenic diet enhance performance? One thing that the endurance athletes tell us is that when they're keto adapted, they're much less likely to hit the wall.
Yeah.
That is, have the central nervous system begin to shut down, saying you aren't providing me enough glucose to keep my brain functioning. So they can go for longer periods of time, and that appears to be that because the brain can function very well on ketones, and it's not glucose dependent. Mm-hmm. And so for events lasting longer than 3 or 4 hours, where normally, like in a full Ironman triathlon, they have to eat continuously during the running and the cycling legs of those events. The athletes find they need to eat far less calories in race in order to sustain performance. So that's one aspect that's beneficial. And the other is what we call power to weight ratio, that many athletes find that no matter how hard they train, they can't train themselves down to an ideal low level of body fat, say under 10%. And for some athletes, getting under 10% is really important in terms of the power to weight ratio. And they find that when they adopt a well-formulated ketogenic diet, they're better able to achieve that optimum percent body fat that optimizes the ratio of muscle to muscle weight to body fat weight. And again, for those athletes, oftentimes they will train on a high-fat, low-carb diet to get ideal body composition down. And then they can add back what they call strategic carbs, either immediately before or during an event in order to optimize glycogen as well. And again, this tends to be athlete-specific. Each athlete needs to have some guidance, but their own experience in figuring out what works best for them in terms of the degree of carbohydrate restriction and the amount of carbs that can be used strategically to maintain optimum performance.
Yeah, and I think we've talked a lot about resistance training or endurance training, but I think resistance comes up a lot too. I think there was a study recently, I hope I'm not misremembering this, I think it was out of Dom D'Agostino's group, or he was involved in it somehow, but they looked at 10 weeks of Western diet compared to a ketogenic diet, and similar gains in terms of strength and power during that time, and also similar losses of body fat and muscle gain between the two groups.
Yeah.
So it doesn't appear to impair performance in any way.
And not to get too far ahead of the data, but Professor Volek at OSU has completed the data collection from a study they did with a high carb versus a ketogenic diet in a group of student athletes where they did a intensive resistance training program. And hopefully those data will be reported this year, but it will, I think, emphasize the benefit in terms of resistance training and maintaining lean body mass and optimizing power to weight ratio.
Sure. I think the power to weight ratio is a really important point. All right. Our next question. Are there any benefits of fasting that you can't get through a well-formulated ketogenic diet? And what do you think about autophagy and apoptosis?
These are hot buzzwords right now in the research community. There's a lot of research been done with basically animal models. And what people talk about autophagy and apoptosis is basically changing either, regenerating cells from aging cells, regenerating with replacement cells, and
it's
also
kind of the cleaning system, right?
A cleaning system, but also cleaning up internal cellular machinery, particularly involving things called mitochondria. And mitochondria are those little furnaces inside cells that actually do the oxidative energy generation. That's where oxygen is consumed along with either fat or carbohydrate to replace the high energy phosphates, ATP and creatine phosphate. And so that machinery constantly has to be repaired. And there is evidence that periods of fasting can enhance that process. There's been less research with well-formulated ketogenic diets done long enough to actually look at that. And again, the turnover of cells and the turnover of mitochondria, that is how frequent they're replaced, is measured in weeks or months, not in a day or two.
Sure.
And so particularly for human, to have human-specific results, it takes rigorously done studies, and there aren't that many groups who have been able to sustain ketogenic diets long enough to really look at that. And again, stay tuned, because that's an area where Dr. Volek and his team are on the forefront of doing that research.
Yeah, I think I'm certainly not an expert in this area, but I think autophagy can be stimulated by reduced insulin, increased glucagon, inhibition of mTOR. So it would, I know a lot of the research is in fasting, and ketogenic diets tend to mimic that from a metabolism standpoint in a lot of ways. So I would assume that you would be able to get some similar benefits out of doing it for a long time. Right. Have you tested ApoE genetic expression in study subjects, and does it have any predictive value in identifying so-called LDL hyperresponders? So we did not include genetic testing in this research study, so unfortunately we can't draw any conclusions or make any statements about that. My understanding of ApoE is that one variant of that, ApoE4, is very highly associated with increased cardiovascular risk.
And increased LDL.
And increased LDL, yes. So in this case, in terms of identifying the LDL hyperresponders, this is a very complicated question, because my first question is, what is an LDL hyperresponder? And also, if it's a genetic component, if they have ApoE4, they probably had a high LDL to begin with before changing their diet. So perhaps we don't have any data that would be able to answer that question, but I would think that I would see high LDL in that person before they would even begin dietary changes.
Mm-hmm. So the simple answer is we haven't tested it.
Yeah.
In terms of the doing the genetic testing on our Indiana University Health research population. But the other point is that increasingly the cardiovascular risk area is moving away from a focus just on LDL. So we think of LDL as one tree in the forest.
Yeah.
And then we will be putting up a blog post in the next day or two, basically summarizing what we had in our research paper, so making it a little bit more digestible for the non-science reader, to point out that when we look at a bunch of other factors like inflammation, like hypertension, that when we look at those other risk factors, so many of them improve independent of LDL, that even we assume that even people with the ApoA4 genotype would probably still get a net benefit from the ketogenic diet, even if their LDL doesn't respond as dramatically or in the same way that the other groups do in terms of particle size and number.
Sure. I just spent some time at the National Lipid Association conference, and the opinion of a lot of clinicians there is that they like to use non-HDL. So even with LDL being a target, they tend to also have a target of non-HDL, and National Lipid Association promotes that. So I think the idea of relying on more than one marker is certainly catching on in clinical practice. So if you're just joining us, we just want to welcome you to the Virta Facebook Live Q&A. This is Dr. Stephen Phinney, and I'm Dr. Amy McKenzie. If you like this event and you want to know about more in the future, you can follow us on Facebook by following Virta Health. Our next question says, is it possible for a person to have a really high hemoglobin A1C and yet have decent triglycerides, meaning 150s or lower? Suppose it's possible.
It's, on average, the higher a person, or the less controlled a person's type 2 diabetes is, so the higher their hemoglobin A1C would go, the more likely they are to have what we call atherogenic dyslipidemia, which it involves a low HDL and a high triglyceride. So on average, high triglycerides and high hemoglobin A1C values go together. But people vary quite a bit one from another, and it's very possible that somebody could have a triglyceride under 150, which is the upper limit of considered normal. We like them under 100. Yeah. And still have a high hemoglobin A1C. The other factor is triglycerides can go down very quickly when you cut out dietary carbs. But your hemoglobin A1C value takes 3 to 4 months to change. So one might see triglycerides plummet in the first, say, month of a well-formulated ketogenic diet. And the hemoglobin A1C is going to tag along quite a bit behind. So typically we wait anywhere from 4 to 6 months after people make it the change to a low-carbohydrate diet before we do that testing, so that the hemoglobin A1C can, which is a slow responder, catches up to some of the factors which respond more promptly.
Sure. So this comment is, hi Amy, congrats on the award. Thank you very much. Is there a rough estimate of when 2-year Virta results get released, and are coronary artery calcium scores being calculated as well?
Tell us about the award.
Oh gosh. So I mentioned the National Lipid Association, and we had submitted an abstract there. On
with you as first author.
Yes. Definitely a team effort from the whole group. We submitted an abstract focusing on the cardiovascular risk factors and their response at 1 year to our intervention. And also because of this concern about LDL, we also took a closer look at the change in LDL over time. So we compared early to late change in LDL. And what we saw is that people who had an early rise in LDL, either LDL-C or LDL particle number, in the first 10 weeks, later saw a decrease in a similar amount, and those who had an early decrease had a later rise. So there's a lot of potential explanations for this. One is probably partial to Dr. Phinney with, in this case, so if somebody has an early rise in LDL-C and they're losing weight, a lot of weight, a significant amount of weight in that time, there's a chance that their cholesterol will go up during that weight loss, right?
Correct.
And that it'll go back to normal following weight stabilization.
And that appears to be because when people carry a fair degree of extra body fat, it soaks up cholesterol. When you lose the body fat, it has to be mobilized. And so there's a transient mobilization phase. So again, we don't draw conclusions, even after 3 or 4 months, if people are losing weight, from the the measured cholesterol levels. We wait usually till the end of a year. Most people have stabilized their weight by that time, and that gives us a more steady state measure of the cholesterol distribution within circulating lipids. But there was a Young Investigator Award, and of the abstracts submitted to this national meeting, Amy was the recipient of that award. Congratulations, Doctor.
Thank you. Definitely had some good mentors along the way to get there, so thank you. So we presented this at the National Lipid Association conference last weekend. Feel free to write to us and ask us more questions.
And then the other question is, when are we going to release our 2-year data?
So 2-year data. We're 2 years into the trial now. Can you believe it?
Yeah, we're
we're
more than 2 years in, but we've recruited people over about an 8-month period.
Yep.
And the last people recruited 2 years ago have now completed their 2-year time point. So we're collecting the data and we're analyzing that. We can't tell people about it until we have it accepted for publication. And again, this is sometimes pretty controversial data, and it takes a while, but we hope by later this year we'll have that data published in the peer-reviewed literature and be able to share it with this audience. Yeah.
And then in terms of coronary artery calcium scores, we did not include that as part of the research study, although I know that sometimes it's used in the course of clinical care, but unfortunately not part of the research study. We did do carotid intima media thickness measurements.
Yeah, that's an ultrasound of the carotid artery to look at the thickness of the lining of the artery. And at 1 year, we did not see any threatening changes in the population on the ketogenic diet, in spite of the fact that they're eating a lot more fat than our parallel control group. So that's reassuring that it wasn't getting worse, and we're hoping at 2 years that we'll may be able to see a difference between the control population and our intervention population.
We'll test it and find out. All right. Our next question is, what definitive total cholesterol numbers that are healthy for men and women? What definitive total cholesterol numbers that are healthy for men and women? Sorry, I can't read today. And can you more clearly elucidate LDLP, small LDLP, LDLC, HDLC, and what one should look for?
First point is these are not standard tests that are available to all of us.
Yeah, with the LDLP,
But so particle size and number still remain research tests. And if you can get them done, then you would need to talk to the physician that you went through to have them ordered to be done. In terms of total cholesterol numbers, again, that's turning out to be one tree in the forest or a couple trees in the forest. And again, we have no reason to dispute the total cholesterol and calculate LDL values, except they have to be viewed in the context of a wider range of risk factors. But we can't get into specific numbers for individuals at this point.
Yeah. All right. So if you're just joining us, we just want to welcome you to the Virta Facebook Live Q&A. You have Dr. Stephen Phinney and I'm Dr. Amy McKenzie. We're here to answer your questions on diabetes, heart health, and ketogenic interventions. Our next question is, has research been done to determine if there is a point at which high amounts of sodium supplementation can be dangerous or unnecessary? So there's a paper that looks at sodium consumption and mortality, right? And this is...
There's been a lot of research on that.
Well, I'm thinking of one. I think you know what I'm talking about. O'Donnell?
O'Donnell in the New England Journal of Medicine from 2014. If you go on our blog, we have a posting on sodium intake and why adrenal fatigue is not a real medical issue, and this is discussed in that paper as we've referenced there. Sodium is obviously a very controversial area, and people have almost, let's say, very intense convictions, including dispute among mainstream scientists. So this is not a resolved area as yet. But in the study published in the New England Journal by this group, it's an international research consortium studying lifestyle factors and health outcomes in a couple 100,000 people in 17 different countries.
Sure.
It's a massive study called the PURE, P-U-R-E, that's the acronym, study. And they, rather than asking people how much salt did you eat yesterday, they actually got a urine sample from people, from over 100,000 people, and then looked at sodium excretion at that time point, and then their subsequent, assuming that the day before they'd eaten their usual, whatever their usual salt intake would be. Inaccurate if you were dealing with a few people, but when you have 100,000 people, it gives you a good measure of range of sodium intake. And then they looked at health outcomes for 4 years afterwards. And the total mortality and coronary disease, that is heart attack risk for people, was a U-shaped curve. And the bottom of that curve, where the risk was lowest, was between 4 and 5 grams of sodium, not salt, 4 and 5 grams of sodium intake per day. When people went down to the value where the current U.S. recommendations are at 2.3 grams per day, there was actually a measurable increase in risk. Mm-hmm. And under 2.3 grams, again, these are people in multiple cultures in many different countries. But consistently, there's a rise when you restrict sodium severely, and as one increases sodium intake past 6 or 7 grams a day, then the risk also begins to go up. Now, there are some regions and some cultures where people eat a lot more sodium, and there is evidence that that can be dangerous. For instance, among fishing villages in Japan, where the sodium intake may be in the 10 to 15 gram per day range, that can be associated with increased risk of stroke and even heart disease. So again, this is not a blanket permission to eat vast amounts of salt, but particularly when somebody is on a ketogenic diet, which enhances the kidney's ability to clear extra sodium, it appears that the beneficial range for people who don't have significant heart or kidney, already have significant heart or kidney disease, the beneficial range is in the 4 to 5 gram per day of sodium intake range.
Yeah, I think an important takeaway from this is that it's always in context. It's always for an individual person. You have to consider all of the different things that they have going on, and we can't give a blanket across the board kind of recommendation. But
if somebody has fluid retention or hypertension, high blood pressure,
much more careful
requiring diuretic therapy, we get people onto the ketogenic diet and get them keto adapted. And typically we withdraw the diuretic medication. Then we begin to gently add back the sodium to optimize their circulatory reserve, their well-being, and their function.
Yeah.
So again, this has to be individualized, and as Dr. McKenzie says, you can't give blanket recommendations, and we're not doing so here.
All right, our next question is too many calories and too much fat. What is your take on these issues and the low-carb, high-fat way of life? Will hitting your fat macros lead to weight gain? Well, I'm going to start with saying basically what we just said, is that it's very individual, and I would say, what's your goal? Is your goal to lose weight? Is your goal to maintain weight? Is your goal to build strength and muscle? All of these different factors are going to change what your macros may be. At Virta, we handle this a little bit differently. And we really focus on, we're trying to treat type 2 diabetes. We really focus on carbohydrates, getting an adequate amount of protein. And then in terms of the fat, we don't count calories and we don't prescribe a certain amount of fat. We really teach you about hunger and satiety, and we encourage people to eat fat to satiety.
So we try to stay away from macros, because when somebody comes to us and they carry extra weight and they want to lose weight, it's what's coming in is different than what the body's burning. That's how people lose weight. And so again, as Amy said, we individualize carbohydrate intake to a restricted level where they can get into nutritional ketosis. We guide them to eat protein in moderation, but enough to maintain lean tissue and function, but not to overeat protein. And then we counsel people to eat fat, add fat to satiety. And what that means is trust your instincts.
Yeah.
And so often with people, when they're eating a high carbohydrate diet, they don't get that sense of satiety, and they're surprised that, hey, there's still food on my plate, and I'm satisfied. Mm-hmm. And we coach people through that process. And one's natural instincts are, after significant weight loss, is that the body will basically give a person signals that, you need a little more fat.
Yeah.
But we don't counsel people to eat a specific amount of fat, and we definitely don't tell people eat more fat to make your ketones go up, because that doesn't work. Ketone production is a function of how much carbohydrate you eat, which is the biggest driver, keeping it low enough to maintain the liver in a state where it produces ketones. Not overeating protein, which protein is not a very potent suppressor, but it's a moderate suppressor of ketone production. And then the other factor that brings ketones up moderately is adding a moderate amount of endurance type activity. Mm-hmm. And if people have the energy level and they don't have the lower extremity and back problems that prevent exogenous, then exercise can be a factor as well.
Yeah, and that's, for many of our patients, it's been a really successful component, is just getting moving in terms of a walk after dinner or something like that. Mm-hmm. Been really helpful for a lot of people. But
we don't encourage people to purposely add a specific amount of fat to the diet, only to add fat to the point where that meal, that day, they have adequate sense of satiety that they're not constantly thinking about and obsessing over food.
Yeah, I certainly hear people say, well, if I add more fat, will it help my ketones go up? But as you mentioned, it's not the main driver. And then if you have that thinking, then you're potentially getting more calories than you really need, and potentially stalling weight loss if that's your goal.
Yeah. Again, so, the process of keto adaptation gives the body permission to burn fat at twice the rate. And at least initially, it doesn't care whether it comes from inside or from the mouth.
Yep. All right. Our next question. Is there a protocol for using the ketogenic diet as an adjunctive therapy in the treatment of cancer?
Again, a hot topic.
Working on this.
There's a lot of animal research going on. There have been a fair number of human case reports and small uncontrolled studies that have been done. There is now a lot of interest in doing controlled, larger cohort studies. And again, not stealing Dr. Volek's thunder, but he has one underway at Ohio State University. But to my knowledge, there are no published protocols at this point for treating specific forms of human malignancies or cancer with a ketogenic diet. And that, hopefully that will be forthcoming and with high quality research within the next few years.
Yeah, I think when we were at the Global Symposium for Ketogenic Therapies, they were discussing this and talking about using ketogenic diets in treatment as an adjunctive therapy for glioblastoma. Mm-hmm. But it was a few case studies or a case series. But yeah. Again,
it takes, as we've discovered and at Virta, it takes a lot of education and support for people to know what to eat and how to sustain a well-formulated ketogenic diet. And there is a potential application for Virta going forwards in providing our continuous remote care to support these kinds of studies.
Sure.
But again, that's something we look forward to in the future.
Mm-hmm. All right. So if you're just joining us, we just want to welcome you to the Virta Facebook Live Q&A. We have Dr. Stephen Phinney here with myself, Dr. Amy McKenzie, and if you would like to tune in again and join our future events, you can follow Virta on Facebook. Our next question says, many have great concern about eating protein and fat if they have kidney disease or if their doctor warns them that a ketogenic diet may cause kidney problems. Can you address this?
Yes.
Yes.
I would say the risk to kidney function from dietary protein intake is based more on presumption than data. Mm-hmm. Just when protein is eaten in moderation, there is very little evidence in when people have normal or even modestly impaired kidney function that will negatively affect kidney function. Sure. In our 1-year data from the IUH study that we published a couple months ago. The commonly used measure of kidney function is something called serum creatinine.
Yep.
And that's a product that's produced metabolically in the body and has to be cleared by the kidneys as a waste. And the level of creatinine over the course of a year in people with pre-existing type 2 diabetes, so their kidneys are already being challenged by their diabetes, the creatinine level went down slightly but statistically significantly in the context of a well-formulated ketogenic diet. So we saw no evidence at 1 year of any negative effects of moderate protein in the context of carbohydrate restriction and circulating ketones. And we will have hopefully data from 2 years that we'll publish from 2 years as well. So again, this is not a high protein diet. That's really, we have to emphasize that. Protein is eaten as when we say moderation, it's in a range that if you're talking about macros in terms of what the body's burning in a day, we're providing 10 to 15%. At most 20% of daily energy intake is protein. Some people advocate higher protein intakes with carbohydrate restriction, let's say with the paleo diet, and that does not appear to be necessary. We don't know whether that's safe or not, but certainly at the levels that we counsel people to do this, we have every evidence of improving kidney function, no evidence that there's a negative impact on renal health.
All right. I'm pretty sure this is a question for the physician. Could diazoxide
be helpful?
Be helpful to ketogenic dieters? I have no idea.
It hasn't been studied.
Can you tell us what diazoxide is?
It's a therapy that's used in acute care medicine for people with severe hypertension.
Okay.
It does have metabolic effects that might be beneficial, but it's a prescription medication, and I don't know of any evidence that it would be any better than naturally occurring ketone production. But again, it's an area where I don't want to speak from presumption, and I don't know of published evidence that would support its use.
Okay. Do we need to supplement iodine since we are using sea salt? If so, how much?
Most commercial salt is supplemented with iodine because if people don't get enough iodine, they can have impaired production of thyroid hormone because it has each molecule that the thyroid makes has to have 4 iodines on it. In the past, in areas where people aren't close to the ocean, where seafood contains a fair amount of iodine, even if sea salt doesn't. Iodine depletion can lead to what's called goiter, that the thyroid gland hypertrophies because it wants to make more, but it doesn't have enough of the mineral. If somebody takes a standard basic multivitamin. That contains plenty of iodine. Much of the salt that's used in food preparation is iodine supplemented. So again, prepared foods will have it in it, even if one chooses to eat a version of sea salt that's not been iodine supplemented. So we don't have any evidence that folks eating a well-formulated ketogenic diet and using sea salt rather than commercial supplemented salt will see an iodine deficiency. Theoretically possible. We do counsel people that a 7 cents per day standard low iron multivitamin is a very, very inexpensive insurance policy that will do no harm and will cover some of these basic issues were they to ever become a factor.
Sure. Our next question is, what is the maximum limit grams of carbs for weight maintenance? This is a very challenging question what is the maximum limit of grams of carbs for weight maintenance? It's a very challenging question to give an answer to broadly. I think it depends on the person.
Sure. As Jeff and I think, if not coined the term, certainly promoted the concept of diabetes as a form of carbohydrate intolerance. And diabetes is a disorder of type 2 diabetes is a disorder of predominantly of insulin resistance. When people reverse that with a well-formulated ketogenic diet, they can increase their carbohydrate tolerance. At the other end of the spectrum, there are people, and we know people who eat a lot of carbohydrates on a low-fat diet and remain very thin and very healthy. They have a very high carbohydrate tolerance. So we range as humans from very carbohydrate intolerant, that's type 2 diabetes, to those skinny, high-carb people who seem impervious to even a high intake of refined carbs.
Sure.
And they're highly carb tolerant. So we humans vary in a range. And then we vary with age. And I will just say 30 years ago, I was much more carb tolerant than I am now. And so, for me, 50 grams a day of carbs is about all my metabolism will handle without having health effects. But other people can handle 100 to 150, 200. So again, it has to be highly individualized. And so we don't have rigid prescriptions. And at this point, people really have to find, through coaching and a bit of trial and error, what works for them. And that's part of what makes the Virta treatment complex and why it makes it difficult to put into a standard cookie cutter approach.
Yeah, definitely individual to each person, what their goals are, what their insulin resistance is. Definitely have to work with each person individually. Our next question says, are there discrete groups of people who tend to be at greater or lesser risk of losing muscle mass if protein intake is too low? How about groups of type 2 diabetics who react differently to different levels of protein?
We do know that people vary in their protein needs. There have been very rigorous studies done in the context of a, quote, balanced diet. And actually, when I was a graduate student at MIT many decades ago, some of my teachers there were doing studies to measure precisely how much protein the average normal person needed. Now, I don't want to cast any aspersions at students at my alma mater, but they were using MIT undergraduates as their normal subjects. And some people from Harvard might say that those weren't really normal people. Just a little bit of Cambridge politics there, sorry. But what they found is that keeping the protein intake very low, down to the point where the people were just hanging on to their existing lean body mass, was a specific number. But some people were doing just fine at that, and others were losing lean tissue. So the group average doesn't represent what the individual needs. So there is quite a bit of human diversity in terms of their protein needs. We also know that that protein need goes up with aging, that the older people tend to be less able to maintain lean body mass when protein is restricted. And then illness, particularly inflammatory illnesses, can increase protein requirements. And certain medications will increase protein requirements. So again, there's a lot of variability. The number we've chosen to focus on, which centers around an intake of what we call 1.5 grams of protein per kilogram of reference weight, which is, it basically makes some assumptions about how much lean body mass a person has. We picked that number because for the vast majority of people that we've tested, that turns out to be an adequate amount of protein with some buffer, but not so much that it suppresses ketone production. And so again, but our coaches will work with people if they're struggling to get their ketones up in a good range. They can dial back a bit from that level of protein. Other people, if they're doing resistance exercise and want to build lean body mass, they can add a bit more as long as it doesn't compromise ketone levels. So again, it's individualized through our biometric monitoring and our coaching.
Yeah, one thing that I was really surprised about when I was working clinically was patients who gained lean body mass once they started doing a ketogenic diet. Can you talk about that a little bit?
Well, we've seen that in metabolic ward studies, that some people come in perhaps because they've been doing restrictive dieting for an extended period of time. And again, when you restrict calories, the body becomes less efficient in use of protein. So people are constantly restricting, trying to lose body fat, may end up also compromising lean tissue. When we get them on a well-formulated ketogenic diet, the fascinating thing is satiety goes up. They no longer feel like they're restricting, but they're eating fewer calories, and yet they gain lean body mass. And that implies that there's something about the nutritional ketosis that enhances the body's ability to build and or
build
recovery
muscle.
lean tissue. And we hear that from athletes as well, particularly around the
Certainly.
recovery point. Again, areas that we see evidence that is there, but we really haven't had the resources to study it rigorously.
Our next, sorry. We have time for 2 or 3 more questions, so please ask yours in the comment section under the video. What is the best time to test for blood ketones to verify ketosis? We've gotten quite a lot of these it depends questions today. So this is another one of those it depends questions, so I apologize. It really varies between people. In general, I would say most people have lower ketones in the morning and higher ketones in the early afternoon, evening, generally kind of in the before dinner time range. But I've definitely seen exceptions to that rule too. So I think this is something that it's good to test at a lot of different times and see where you are at different points in the day. It's also good to test at different times to understand how your body reacts to food, how your body reacts to exercise, and you can really understand how you work with this. But then ultimately it's up to you, and it's up to you and how your pattern works and really what you're looking for.
Mm-hmm. In the past, we thought that ketones primarily were just a good replacement for glucose to feed the brain.
Yeah.
Which means you had to have them there all the time because your brain is burning energy continuously, minute by minute. And so we thought ketone level should be up in a good range all the time. And now it turns out that ketones, particularly beta-hydroxybutyrate, has almost a hormone-like action, signaling various cells in the body to do things. And some of those come through changing gene activity as an epigenetic effect. And that may be something that if one gets up into an effective epigenetic signaling range at some point during the day, the benefits will carry on. And so there's more to be explored here. But as Dr. McKenzie implied, people vary at different time points in the day. Yeah. And if you want to get positive feedback and see a good, quote, a higher level, test yourself typically in the afternoon after a half an hour of anything from a vigorous walk to working out in the gym, and it'll probably go up.
But if you want to know your lowest, you test at your lowest time point. So it really depends on you and what feedback you want to get. So our next question is, have there been any updates to the literature around taking exogenous ketones for general health, energy, and neurological disorders since your March blog post? I don't know if I've seen anything recently. I haven't seen anything that enhances what we already know. Again, this is a very active area of research with ketone supplementation, and research being done at Oxford. Dr. D'Agostino's group at University of South Florida and Jeff Volek at Ohio State University all have active protocols underway. As the range of ketone supplements that can be consumed, the range of formulations is increasingly available, and particularly as the cost comes down, we'll hopefully have an understanding of how best to marry the exogenous ketone usage with also enhanced endogenous production by appropriately restricting dietary carbs. Our next question is, how do you address those doctors who advocate a whole foods, plant-based diet to restore insulin sensitivity and thus control type 2 diabetes and also decrease insulin needs for type 1 diabetics? It seems their way of eating is the complete opposite of a ketogenic diet.
Well, the answer is not necessarily. One can do definitely a low carb and even a ketogenic diet as a vegan vegetarian. It's easier to do it as a lacto-ovo vegetarian, where the majority of one's food is coming from non-meat sources, and particularly from plant sources. And I actually participated in a symposium recently in Chicago where there was a advocate of total fasting for a duration of like 2 to 3 weeks, followed by a plant-based diet, and he presented evidence of reversing type 2 diabetes with that approach. The total fasting was done in an inpatient setting. This is obviously would be a very expensive way of using this kind of therapy. And his data was impressive in terms of the people he selected to present. But these are people who chose to A, pay the money, and B, go through the fasting. And at the end, we agreed very collegial that there are some people who are well suited to do it that way, and there are many people, and certainly we found quite a few of them in the Lafayette, Indiana area who were able to do it with the Virta program. The two are not mutually exclusive. And so in the future, particularly as there are rigorous studies done with the plant-based diet, because up till now it's been more anecdotal and ideological than science-based, but as people demonstrate what percent of people who are recruited in such an intervention can succeed at that, not just for months but for years, we'll be able to offer people basically a menu of options rather than saying this is the way to do it. And I don't think there's one or one cookie cutter approach that fits every human being's metabolic needs.
Yeah, and I also think there's preference and lifestyle choice too, is that you have to, we were talking about doing something sustainable, you have to choose something that's going to work for you both in terms of health and your metabolic needs and your lifestyle. So you have to kind of find the balance between the two, and for some people it might be one direction and for some people it might be a different direction.
Mm-hmm. Yep.
Definitely have to consider what the patient's goals and values are.
Agreed.
Next question says, how will I know if I am no longer insulin resistant? That's a challenging question to answer. We can tell you about your glycemic control. There's certainly a range of understanding your blood glucose and how much your blood glucose varies in terms of, what is your average blood glucose over a period of time measured by A1C. In terms of insulin resistance, I guess gold standard would be the clamp, the euglycemic clamp.
Yeah, there's actually a research test where you infuse insulin in one arm and you infuse glucose in the other arm. You see how much glucose it takes to overcome the effects of insulin.
Sure.
The more standard approach is to do either a fasting insulin and a fasting glucose in the morning, and that is a calculation called the homeostatic measure of insulin resistance, and that's something that can be done by any physician. Mm-hmm. A standard test with just one blood test. If you want to be more rigorous, you do and we don't advocate this, have people drink either 50 or 75 grams of glucose and measure the body's insulin and glucose response over either 2 hours up to 5 hours. But the HOMA-IR is a pretty good test, economical test, and validated in our. What was the reduction in HOMA-IR at 1 year? Was it like 60%?
I don't remember off the top of my head.
Yeah.
It was significantly reduced. Unfortunately, I don't remember the number.
It was a very large reduction.
Yeah.
And so those are the ways to do it. But if you were taking diabetes medication for type 2 diabetes and you're off those medications and your blood glucose control is better and your hemoglobin A1C is down significantly, you've markedly improved your insulin resistance. That you can know for sure.
Definitely. So thank you so much for joining us today. If you'd like to have more information on ketogenic interventions and their effect on diabetes and heart health, follow Virta Health on Facebook and check out our research on virtahealth.com/research.
Thank you.